Today I'm going to discuss the care consultation model. This is something that we developed and have been teaching now for 15 odd years with great success for doctors preparing for various OSCE type examinations all the way up to membership level. Okay? So one of the things that can happen if people have really complex consultation models or checklists, like I've seen sometimes doctors have got 12, 13, 15 points in their checklist. In a 10, 12 minute consultation, you can be overwhelmed. You can sometimes ask a question but miss the answer because you're distracted by thinking what's next on my checklist just because it's so long. So that's why we developed this, the care consultation model or structure, to deliberately keep it simple. It's called care because that's the mnemonic, which we'll go over in a minute. But ultimately, what makes a great consultation? Really care about your patient and show that care and deliver a high standard of care. You need both, right? It's no good if you're the nicest person in the world, but you don't ask the right questions, can't work out what it is and don't know how to manage it. Equally, if you get the diagnosis right and know how to manage it, but you can't deliver that in a caring manner, you don't show any empathy, your communication skills aren't great, you also might find that you don't connect with the patient and you don't get the ultimate outcome that you want, which is to improve their health and well-being. So it's called care because the mnemonic, right? So the C is for connecting, the A is for assessing, the R is for review, and the E is for the ending. Okay, so the C is the connecting. Start with a polite professional introduction, open with a couple of open questions, and keep an open mind. The nature of general practice is that anyone can come to see you about anything. Yes, you will have done your research and read up their notes before your next case begins in the exam, for example, or before you call in your next patient. But the nature of GPs, I could have a patient who's got a history of back pain, who's got diabetes, and today they've woken up with a really bad headache. And it's nothing to do with their diabetes and it's nothing to do with their pre-existing conditions. Okay, that's the nature of GP, right? That's why you want to keep an open mind and a couple of open questions. How can I help today? What would you like to discuss? And then really listen in that first minute. And in most cases, they're going to give you lots of useful information, especially in an exam setting. If you can encourage them to just keep talking for that first minute, maybe with a nod of the head, a little encouragement, okay? They'll often give you lots of useful information and some cues that you can then follow. Okay, so that's the C. A is for assess. This is the bulk of your data gathering. Don't be scared now to ask some specific closed questions to follow up and narrow down your differential. Okay, so for example, if someone's got a headache, you're going to ask some specific questions that are going to help you work out, is it likely to be a brain tumor? Is it likely to be a migraine? Is it likely to be a tension headache? What side is it? Did it come on suddenly? Was it gradual? How severe is it? Is it there all the time? Does it come and go? Are there certain triggers? Does it get exacerbated when they look at the light? Does it get worse if they bend over? Is it at certain times of the day, like first thing in the morning, for example? Did they have associated symptoms like vomiting? Specific closed questions to work out what's actually going on. Don't be scared of closed questions. There's nothing wrong with that. Okay? That's how a good doctor is going to take it broad. At the beginning, it could be almost anything, right? Hundreds of possibilities when you just hear headache. And you narrow it down by asking these questions. So as part of that, you want to ask about the relevant symptoms, the relevant risk factors. You want to be safe. So you want to rule out rare but serious things by asking about and excluding the relevant red flags. Okay? About halfway through your consultation, you should start wrapping up the bulk of your history and start thinking, is there a relevant examination or examinations that are going to help me work out what's going on with this patient? Okay, and in real life, you're going to do those. In an exam setting like the MRCGP SCA, where it's remote, if there's still relevant examinations, you still might think about and you might discuss that it would be helpful to do this examination because help us separate if it could be this or this. And then that will lead into later on in your management that you're going to ask them to come in so you can do those things. R is for review. So you've finished taking your history, you've thought about examination. Take a few moments for yourself to review what you've found. Because patients often will give you one bit of history, then you explore something else, then there's a cue they give you, you've got another bit of history that might add in to something that was already in the notes, to something that you might find in examination. Suddenly it clicks together. So by taking a few moments for yourself to review what you've found, you should have a very clear idea in your mind of the diagnosis, so that you can then discuss and explain that clearly to the patient. And once you've discussed and they're clear what the diagnosis is, you then can move on to management. And you can agree a management plan to deal with the main problem, but also any other big risks that you've picked up during the history. you want to make sure that you've got a plan to deal with those and arrange a normal follow-up. So that's all in the review phase. Okay, you're reviewing the diagnosis and the management. And E is for ending. Last couple of minutes. Think about safety netting where appropriate. Okay, so you've found someone with a headache that sounds like it's a migraine. You've explained the normal medication they're going to take and how to take it, and the normal follow-up to see how they're getting on with it. But if it changes and you start getting, first thing in the morning, you wake up with a series of headaches, you start finding your vision's affected in a different way to, sometimes people can have some visual symptoms around the time of their migraine, but you start just getting double vision that's there all the time, and you think that, okay, that might be a warning that it's something else, but you ask them to come back. Okay, so you've got your appropriate safety netting, and then extras. So anything else that you might need to organise follow-up, maybe a secondary issue you don't have time to deal with, but it's still important, that's something to deal with at the end. That, look, it'd be really helpful if we had a separate appointment to talk about this issue, so that we can do it thoroughly and I can give you the appropriate time that it needs so that we can actually explore what's going on. Okay, so just to recap, C is for connecting. Polite professional introduction, open with open questions, keep an open mind, a lot of listening at the beginning. A is for assess. Now take a focused, concise history. Explore the relevant symptoms, risks, exclude the relevant red flags, start thinking about examination once you get just around past halfway. R is for review. Take a moment to review what you found so you can explain clearly the diagnosis and the management of the main problem and any other big risks, including follow-up. And E is for ending. So think about the safety netting and any extras. You're going to leave that towards the last couple of minutes. Okay, so that's a care structure. And the specific questions that you're going to ask, they're going to be different each time based on the symptoms. You still need to be natural, so you need to respond to, pick up and explore cues. Okay, that all comes with experience. Seeing enough patients, consolidating your knowledge base so you know the guidelines, so you know what are the right things to ask. But if you can have that as a broad structure to manage your time, it means that you're not going to miss anything important, but it also means you're not going to be formulaic, and you can really focus on the listening to the patient and responding naturally. So that's a care structure. Hope you found that helpful. Let me know if you try to implement it in practice how you get on.